And now it's my honor to introduce Tom Reisenbichler. And then Tom, you're going to introduce your team for today's lecture. So Tom, FAIA, is a principal and manager director of the Perkins&Will office Dallas. And Tom doesn't like to sit still for long, bitten by the entrepreneurial bug during college. When he first attempted to put together a real estate deal, he has since launched multiple businesses, including co-founding the architecture firm that later became part of Perkins&Will. And that's really impressive. And Tom habitually and purposely looks for opportunities that get him out of his comfort zone in work and in life. Ask him about his amoeba metaphor, which I don't know what exactly it is, that Tom may explain that a little bit during his lecture, which is really famous around the Dallas studio. He considers architecture to be a type of puzzle, which he's always enjoyed and is always looking for ways to design in a different and better way. Now that he's an empty nester, Tom finds more time play golf, attend the theater, and host gathering of friends. And he and his wife are adventurous travelers who enjoy active, exotic vacations. Kenya is a current favorite, and he still wants to visit Morocco and Tibet. So Tom, please take the mic and then introduce your team and begin your lecture. Thank you so much, Tom.
Okay, well, thank you. I will tell George that when we first met, I had hair also, but you know, that was a long time ago. But thank you guys for letting Perkins&Will be part of this series, and we are looking forward to sharing information and hopefully getting more Aggies interested in working with Perkins&Will. So I'm going to give you a quick overview. Jean Ma, who has kind of a legend in healthcare design, is an Aggie, and I think she was the first female graduate from the School of Architecture at A&M, and she has led our healthcare practice for many years. And I don't believe she's on yet. She will be joining a little bit late because she had another presentation ongoing, so she'll probably hear from her later. And then Diana Davis is the managing director of our Houston practice and also leads the healthcare planning in Houston. Andrew Koska is an associate principal in Houston, and he will be sharing, as will Sarah, both from Houston, will be sharing a lot of information about a particular psychiatric behavioral health facility that is really an amazing project that we're really proud of. So they'll be sharing some information with that. And then Kevin Turner is actually not part of Perkins&Will, but used to be part of Perkins&Will. And we've had a long relationship when Kevin was part of our firm. And since he's left and founded the Human Experience in Charlotte, we continue to work together. And he's a pretty important part of our behavioral health program. So just to give you a quick overview of Perkins&Will, founded in 1935, so been around many, many years. We have 14 areas of practice, the largest of which is usually goes between healthcare and corporate commercial. We have 26 offices and 3 in Texas. So, you know, we're always looking for great people, but if you don't want to live in Texas and want to go somewhere else, then we have many opportunities around the world for Aggies. We can always use that kind of great talent. So next slide. This kind of gives you an overview of where the offices currently are, and we're always growing and expanding. And the best thing about our firm is we call it a world lab because we share information back and forth constantly. We have the Healthcare Center of Excellence that allows us to gather data and gather information from our other offices and colleagues around the world pretty much instantaneously. If we have a question of, has someone ever done, you know, a cath lab underground or something odd like that, we can email the COE and answers come back and examples come back from all over the world. It's really a great resource and works as a world lab. We are always ranked in the top firms in healthcare, particularly interior design and architecture separately, but jointly, we are always in the leading groups along with several other firms. And a lot of those are office in Texas also. So it's a great collegial group of firms at the top there. One of the things that we are very proud of is the most innovative companies in architecture, according to Fast Company magazine, because that is something that is given to us by a non-healthcare magazine or a non-architectural magazine. So it's recognized from the outside the industry as a big contributor to innovation in our business. The next slide. This kind of gives you an idea of how our practice council works. We have leaders around the country and globe that are part of our healthcare council, and they are always helping to make sure that we are at the cutting edge of healthcare design and planning, helping make sure that we are thinking about all the different aspects of what it takes to build a really good quality healthcare practice, everything from planning and strategies. We have an innovation incubator where we actually fund innovative ideas that the staff bring forward so they have time to research and develop innovation. The Center of Excellence I already mentioned, and we do a lot of research that is published, not necessarily quarterly, but whenever we have the right amount of information that we can share. It is a research journal that's published. It's really a good asset, and our clients enjoy seeing that. So I think that kind of covers Perkins&Will. With that, I'm going to turn it over to Kevin Turner, who, like I mentioned before, we regard, even though he's not part of Perkins&Will anymore, we regard as a partner in the behavioral health practice, and he's a great asset for us. So Kevin, I'll let you take it away.
Sure. Well, very quickly, Human Experience is the firm that I founded when I left Perkins&Will, and primarily what we do is behavioral health consulting. So I have a partner, Sherry Reyes, who is not an architect, but is actually a experienced behavioral health executive. And so we're able to embed with an architectural team, as we've done with Perkins&Will on these projects, and provide a lot of consulting that helps them really deliver great design for their client. So that's essentially what we do.
Kevin has always been a great collaborator for us, not only because of our shared history at Perkins&Will, but because we also share a philosophy around the way we approach the design and planning process. I know for a fact that this is a philosophy that's also shared by Kirk and George and all of the instructors in your great program as well. Thank you for having us here. We wanted to kick this off by talking a little bit about that philosophy and how that relates to healthcare design, because I believe it'll frame the conversation that we have as we move forward and compare two of our key examples of recent behavioral healthcare environments that we've been designing. But we really strongly believe that the expertise that we gain as healthcare designers isn't about finding a fixed set of solutions or formulas that we can just carry from project to project and implement, but it's about using that experience that we get through our work to ask the right questions and to primarily listen carefully to the answers that we get. There's a saying that some of you may have heard that goes, if you've done one hospital, you've done one hospital. And there are any number of building types that you could substitute for hospital in that statement, and it still applies. But what we really find exciting about healthcare design is that we get to work with so many variables, and those variables change from engagement to engagement based on economic conditions, location, philosophy of care, operational models, etc. What we are always hoping to do with our clients is to bring them ideas from the range of approaches that we see our clients take, but then help them create the unique solution that best enhances their care environment for their patients and that is most reflective of their culture. So we're going to present two examples to you of environments that were designed generally concurrent with one another. and that are both under construction right now that illustrate how the continuum of care is adapted to behavioral health environments, firstly, but also show how that one-size-fits-all approach is generally very far from the answer. So we're going to start with the behavioral health consolidation that our firm is constructing right now at Duke Regional Hospital. This is an addition to Duke Regional. It's in Durham, North Carolina. And about 4 years ago, the leadership at Duke Health decided to consolidate their inpatient and outpatient behavioral health services onto one central campus, but outside of their main medical center. To address the continuum of care, this center provides services that span the spectrum of crisis care, which generally is a 48-hour window. That's kind of the shortest time frame that you see here. Post-crisis care, which can cover a stay of days or weeks, or sometimes, sadly, even months, and daily maintenance care, which is ongoing care for behavioral patients that could go for as long as is needed in that patient's life. This project specifically is designed to be a 2-story pavilion that's connected to the main hospital, but with a separate intake area for general and behavioral health emergency department services, and includes a 2-unit inpatient treatment area, as well as outpatient clinics and treatment modalities. The project required both an addition and renovations to the existing hospital to expand the existing emergency department and connect these new units to services and support infrastructure within the hospital. Fortunately, the south and west sides of the campus that are opposite where this new addition was are very busy, close to most of the parking for the campus, a major intersection, a lot of dense development at that corner. But we were fortunate in that, we were able to create this new pavilion on a side of the campus that felt a bit more rural, that looked out across a county park even. The new pavilion is designed as 2 forms to create an easy identification of the separate emergency department entrance and the behavioral health services entrance. This both simplifies access and, we feel like, reduces stigma. We clearly and prominently marked the behavioral health entrance, in fact. The 2-pavilion approach also allowed us to maximize the square footage on the ground level, where the emergency department and the outpatient clinics are located, while we could take the top level and start to carve into it to create the courtyards that are beneficial to and typical of behavioral health care. What you're seeing on the screen here are the floor plans for those 2 floors I mentioned. On the left, you're seeing the emergency department renovation and expansion. That was one of the drivers of the project, is how we could, as much as possible, seamlessly knit those together while tying the behavioral health ED to the spine of behavioral health services that we were creating, and be able to have, discrete entries for the patients that might be being brought by ambulance or even sometimes law enforcement. You'll also notice that it's the section close, I don't know if you're able to see the hand move on the screen, but near where the number 2 is that behavioral health emergency department. You'll notice that we've tried to give as many of the rooms as possible access to daylight. That unit is also different from a typical ED in that we included day rooms and other amenities that are more akin to a behavioral health inpatient unit. The count is, we added 18 psychiatric ED beds to their emergency department. Those are grouped into 4 neighborhoods for adults, pediatrics, folks who are considered high aggression. And then we've got a flex wing that can accommodate geriatrics or other patient populations. What this ED does is allows you to provide crisis stabilization in a way that can keep many of the patients that arrive here from having to be admitted into the behavioral health inpatient units. So it in fact frees up beds that might otherwise have gone to patients that were needing to be moved out of an emergency department environment very quickly. We have the facilities here, slightly larger rooms, access to a courtyard. So they're able to keep patients in this emergency department long enough to really determine if they can stabilize them and discharge them without having to admit them here, or get them connected with outpatient care. And then above that, kind of where the 5 is on the left-hand drawing, is the outpatient behavioral health treatment clinic. That includes 29 treatment offices, group therapy rooms, exam rooms. There's also teaching space. This is an academic medical center, and we'll talk more later about what that means. And then on the right, you're seeing the plan for the inpatient units that sit above the emergency and outpatient treatment zones. So we have 42 beds organized into 2 units. One is 20 beds and one is 22 beds. And then each of those units is subdivided into neighborhoods with a nurse station and a day room. This project also included an ECT suite, which is a treatment therapy for acute depression. We'll also talk a bit more about that at the end of the presentation. This is a section through that behavioral health entrance. And that is a space that is a central access point for all of the behavioral health services. Patients arriving for outpatient care or the ECT therapies use this entrance, as do all of the visitors who are coming to those inpatient units. They are led up an appealing staircase. We also, of course, have an elevator core to a visitor lobby on the 2nd floor. We've designed the building so that all of the visitors have a sense of the courtyard above as they enter and work their way up that staircase. You'll notice that the courtyard, which you see near the number 7 in the upper left, is designed with a screening device that allows patients to take advantage of breezes and views out, but it is angled such that passersby on the level below can't look up and see their identities, kind of preserving their privacy while they're in these units. This is another section that is through the connector between those 2 inpatient units. But it's meant to show the variety of programmed outdoor space that we designed into what is really a very tight footprint facility to aid the healing process. This project really is kind of a Swiss watch of outdoor courtyards that have been carved into this pavilion. The one at the bottom is specific to those behavioral health emergency department patients. So it allows them to have access to outdoor space during those emergency department, potentially, longer stays. And then above, there are courtyards that are separated by a visiting area One is programmed for more of an active environment, and the other one is a quieter zone. And with that, I'm going to turn it over to Andrew Koska, who'll take us through an overview of the project in Houston that we're doing right now.
Thank you, Diana, and thank you, everybody. I'm class of 2005 Masters of Architecture from a program from A&M. So thank you for being here. So we're working on a behavioral health hospital here in Houston for UT Health Science Center system. It is currently set to be substantially complete in November of this year. It is a 264-bed hospital with 11 24-bed patient units, a patient therapy mall, admissions area, pharmacy, education center for residents and staff, a dining area, administration offices, and an ECT suite. There were a number of stakeholders on the owner and operator side. The project was initiated by the UT Health Science Center here in Houston in cooperation with the Texas Health and Human Services Commission. And we go HHSC is the acronym. The facility will be owned by HHSC and will be occupied and operated by UT Health. Physicians and educators will who will support the care and research provided here are part of the McGovern Medical School, which is a department of psychiatry and behavioral sciences. The current facility, the Harris County Psychiatric Center, or HCPC, is part of the Harris County Public Mental Health System, and it is also operated and staffed by UT Health. Our project site is directly adjacent to HCPC and also on the edge of the Texas Medical Center, just east of Highway 288. The site is surrounded by multiple uses and scales, which is very typical here in Houston, including existing educational facilities and residences to the south and east of our site. A walking trail provides a separation between our project site and the residential area to the south and east. Because the site sits adjacent to the outdoor recreational areas at the existing HCPC, we were able to utilize that zone as a shared green space for patients, as well as pedestrian thoroughfare for the movement of staff and providers between the two facilities. The other side of the site then made the most sense to consider that as the service entry, that's very near the trail. The existing parking lot was sufficient. It's a TMC-owned parking lot in order to serve both facilities, which was very good because we ended up using every single bit of our project site for the scope of this project. We began the design process by defining the goals of the project with all representatives, and there were a few, as I mentioned. Because this was going to be a UT Health operated facility, it was important to understand how this building would present itself to the community, extend the UT Health brand, and facilitate healing. So it was critical as well that we understand the operational model that would be employed here. Because providers could be moving between the existing HCPC facility, we wanted to address any desired improvements in the patient care environment without creating a completely different model of care between the two facilities, and that was very important. We agreed early on that 24 patients was the best number for the patient unit, and we began doing our planning studies, as you can see here, between 3 different types that we had explored: type A, B, and C, of which we landed on eventually on type C. At the same time, we had our designers working on and testing how these various type units would configure themselves on our site to optimize daylight into the units, as well as access to outdoor green spaces. And you can see these were all the different options that we came up, that we studied. It was very important to everyone that we respect the scale of the community behind the facility, as I mentioned, with all the residential homes, but also the low-rise nature of that existing HCPC hospital. We were given the latitude to explore many different design ideas to push the aesthetic of the look and feel of this new hospital and adjacent to the HCPC hospital. This, as you can see here, was the study that was selected, and it was basically showing how the basic plan is built from 4 of the C-type patient units coming together in 2 connected bars. The 2-bar arrangement allowed the possibility of a contained courtyard, which ended up being very vital part of this project. And it kept the overall height as low as possible while still providing a ground floor plinth of support spaces, which was very, very well stacked in our opinion. Next slide. Because patient safety and security were very of utmost concern with this project, it was important to the team that we create a plan that minimized unnecessary traffic throughout the units. And therefore, the new Behavioral Sciences Center is organized so that staff can move across a glass enclosed bridge between the 2 units and interface with the support areas behind the team stations without having to pass through the secure doors to the entry to the patient units themselves. The ground floor, as I mentioned, is our plinth where the support services were planned, including the admissions area, lobby, our main lobby, the therapy mall for patients, as well as the dining area. We also being an academic hospital, we have an academic component to the program, where we have to the northwest a educational center with conference rooms. The biggest difference between designing a traditional med-surg hospital and a psychiatric treatment facility is where the majority of the treatment occurs. Our focus in a typical med-surg hospital would be primarily on the patient room. And that's where most of the time for the healing is spent. In a behavioral health facility, the goal is to encourage reintegration into society. Therefore, care and treatment takes place in day rooms, as you see highlighted here, as well as other therapy settings, as I mentioned, like the therapy mall level 1. So therefore not so much in the patient room. It is very important that we think carefully about how we can make these spaces as day-lit, flexible, and appealing as possible, and that went into much of the design of this space. And with that, I'll turn it over to Kevin.
Thanks. So you guys have seen a comparison of these 2 projects. What we want to do next is Sarah and I are going to talk about some of the key operational drivers. What's interesting about these projects is they have virtually identical patient types, and we're focusing on the inpatient unit section. They have virtually identical patient types, but they have very different solutions. So we're gonna start by talking a little bit about why that is, and this goes back to the idea that first you have to listen to your client, then you start to design for them.
Hi, so a clear difference in these 2 plan diagrams is the approach to centralization versus decentralization. The diagram on the left shows a unit at Duke Hospital. The single patient bedrooms circle the floor plate, leaving the staff support zones in the center. Each set of 3 to 6 patient bedrooms operate as a self-contained neighborhood with their own day room for social activities. The separate smaller day rooms allow for flexibility in the therapeutic programming, but necessitate staff being decentralized within the milieu. In contrast, the plan diagram on the right shows the UT Health unit. It indicates a centralized nurse station and a large day room. The single large living room creates opportunity for flexibility of function across the space, but does create the challenge of more people in one area. This program includes more intermediate de-escalation zones like reading nooks, quiet rooms, and low stimulation day rooms to provide the patient with the choice of activity and stimulation level in their environment.
So one of the big differences here, and it's driven by those plan decisions Sarah just talked about, is the classic debate of closed nurse station versus open nurse station. And what I want to do is very quickly explain why I just think that's the wrong way to think about this. The UT Health building clearly has the classic definition of an open nurse station. But if you talk to the clinicians at Duke, they would tell you they do not have a closed nurse station. They would say they don't have one at all. Because when we think about a nurse station in behavioral healthcare, we often think of it as a key observation point, and we're thinking about what can you see from there. Duke's operating paradigm doesn't work that way. They observe the patients from on the floor. So what you see in that rendering to the left is a charting room that has glass around it. And that's the way they think about how they operate. And so when you're thinking about nurse station design, centralized and decentralized, open versus closed, the question is not to ask them, do they want open or closed nurse stations? The question is to ask them, how do their staff operate in this space? How do they want to work? And then design the solution that fits for how that's going to be. Next slide. And this is another difference between the two, and it's another example of the importance of listening. The Duke project has all single rooms with ensuite toilets, and the UT project is primarily double rooms with toilets that are accessed off of the corridor. There's research and there's a lot of strong belief in the architectural community working on this, that private rooms with ensuite toilet rooms are better because they provide de-escalation, they provide dignity, they provide privacy. I have found that clinicians are not nearly as convinced as architects are about that. And we do a lot of projects that have a mix of the two, the UT project being farther to the other extreme. And one of the things that drove that extreme at UT is that's how their existing building is. And as Andrew explained, the new building is operating not to replace the existing building, but in addition to it. And as a result, they need to operate the same way across all of their buildings. So a lot of what we did to design this was about taking the unit they have now and reimagining it in modern best practices, but still functioning the same way so that their operational protocols are the same. And one of those was double rooms. Some advantages to that are there's a reduced risk of self-harm because patients have roommates, and there's less toilet rooms, which quite frankly are the most expensive and the most dangerous rooms in the unit. And there's some value in reducing those. So no right answer here, really just two different approaches driven by how the clinical staff wanted to treat, quite frankly, the same patients.
Then zooming back out, we can take a look at the relationship of each of these projects to the larger campus. We discussed previously that the project at Duke was an expansion to an existing facility, and the project was able to take advantage of the existing infrastructure, but also had to respond to the architecture and circulation of the existing building. On the other hand, while on an existing behavioral health campus, the UT Health Hospital is being built from the ground up. This project benefits from sharing parking and secure open green space with the existing hospital and doubles the patient capacity of the campus. As mentioned previously, staff will be trained to work in both of the buildings, so it was important to the client that the new buildings support a similar working style to a building that was designed in the 1980s, while allowing for modern treatment and with an eye to the future. And so the strategies that the design teams use to accommodate the different site conditions are apparent when comparing the circulation patterns of patients, staff, and visitors of these two hospital units. At Duke Hospital, patients, staff, and visitors all use separate vertical circulation. Patients arrive to level 2 via the emergency department at the south end of the plan and must pass through staff spaces to arrive at their unit. Staff and services use an elevator more central to the two units and have quick access to their areas. When visitors arrive via monumental staircase or elevators into the common visitation zone between the two units that we looked at in the introduction. When patients are discharged, they use those visitor elevators, passing by the clinics on level 1 on their way out, potentially stopping by to make a follow-up appointment, as their outpatient care will occur in the same facility. In the UT Health Hospital, all the vertical circulation occurs through the same elevators. When patients or visitors arrive at the unit floor, they will be guided to the left or right through a front entry. Staff and service use a back corridor to access their spaces without disrupting the patient environment on the unit. It is worth noting that the patients at UT Health leave their unit and floor daily to visit the dining, therapy mall, and outdoor spaces on level 1, making the arrival to the unit a very important factor in their experience.
I think, go back to that one quick point. A key takeaway from this that all of you are going to run into as healthcare designers, no matter what you're designing, is that when you have the opportunity to build it from scratch, you can create this kind of diagrammatic clarity that makes it very, very simple how things move. And we put a lot of time and effort into that on the UT project. The Duke project didn't afford us that luxury. And so a great deal of time and thought had to be put into carefully planning out how to take these less clear and more complex routes and think through every challenge that would be encountered along the way and create micro solutions to each of those. So it's just a different way of thinking. It's an important way of approaching a new project.
Great. Thanks, Kevin and Sarah. So with that, you've seen some of the differences between these two facilities, but now we're going to shift over and talk about some of the similarities. These hospitals both exist within systems that are dedicated to academic medicine. That means that they are a part of educating the next generation of psychiatrists, nurses, and researchers, that they are committed to discovering the causes and cures for mental health illness, and that they have a mission to advance the knowledge of patient care while caring for their patients. When we design spaces in hospitals or clinics to support academic medicine, we have to consider a much more robust educational and research support component than we might otherwise for for-profit or community hospital models. So what you're seeing here are highlighted some of the spaces on that ground floor of the UT Health Science Center project in Houston that are dedicated to that academic medical center mission. And you can see it takes up quite a bit of the floor plate. It includes a dedicated education center. As Andrew mentioned in the overview, it's located in almost like a separate support pavilion from the two-bar massing. It has its own entrance, and that allows students, trainees, or people who are coming to maybe attend a conference on mental health issues to be able to come and go and occupy a large classroom or conferencing environment without having to go through the secure space of the hospital itself. We also, on this level, have centralized support spaces for residents and trainees where they can have centralized lounge space, on-call rooms. We also have built into the program space for the researchers who work in this facility to be able to have office space and to be able to collaborate. And then as you move up on the units, we've had to build in some extra space and amenities onto the units themselves for those students who are occupying or doing their training in this facility. You know, that includes providing extra workstations at that central team station we discussed. You know, we have to think about storage for, you know, backpacks and laptops and the things that those folks are bringing with them that they need to be able to access quickly. So we have to think about more storage needs. We also have considered respite areas or flexible team rooms. In this case, there's some flex space built into the office zone that is right off of the unit, so that those kind of casual teaching conversations can happen in an environment with some additional privacy, but with daylight, so that, you know, a lot of times these folks are working incredibly long hours and spend a lot of time on call. So it's a way for them to kind of recharge in a daylit environment. The other component of their teaching is, you know, of course, with psychiatric care, there is a lot of one-on-one counseling that happens. A lot of the treatment is happening through conversation or group therapy environments. So we have a couple of team rooms that are set up with the ability to record those sessions so that these trainees can have those played back with their instructors and talk about, what they've done well and where they need to improve in their engagement with the patients. This is the floor plan of the Duke inpatient unit, and you can see that there's a lot of similarities. In this case, the resident workroom is on the unit. There's additional storage and break room area. So a very similar approach for both of these teaching institutions. Another shared feature of these two projects is that they both contain an ECT suite, and we've mentioned that a couple of times, but I thought it might be good to talk about what that means, because there can be a risk of confusing. ECT stands for electroconvulsive therapy, and it can sometimes be confused with the, shock therapy that, we see in movies like One Flew Over the Cuckoo's Nest, or associate with kind of a bygone era of, psychiatric institutions where, the patients weren't always, they had a bit more of a, antiquated care environment, shall we say. But ECT as a therapy, which does utilize electrical current in its treatment, is actually a growing and relatively new and very effective treatment for clinical depression or bipolar disorder that doesn't respond well to medication. So Duke Health is one of the institutions that's been at the forefront of this research. And one of our missions was to design a suite for all of the components that need to go into that care and treatment, because of course it requires that it be done under anesthesia. So there are support spaces that come with that Kevin will take us through. But we had electroconvulsive therapy suites in both of these patient environments.
Yeah, so one researcher we were working with described ECT as the closest thing to a miracle that we have in modern psychiatry, and I think it's a great distinction, but it's a really unusual process, and so you can't think of it like you would normally think of a procedure suite. So what we have here is two very different approaches, partially driven by different program operational program, and quite frankly, partially driven by space allocation. But what we have on the upper right is the UT, which is a linear space. And what's different about this one is they have a series of beds, which are their pre-procedure and post-procedure waiting areas. So they don't have those separated. So they have an operational system that allows them to manage the flow of patients. They spend much more time in post-procedure than they do in pre-procedure. And so in the lower left, you can see that there are a series of prep rooms, and then they come out of the procedure room and into a recovery bay. And that's a different way of operating because the rooms are set up differently. One of the interesting things about ECT, without getting too deep, is what happens when they're coming through the recovery and recovering from the anesthesia. To oversimplify, ECT is like rebooting your computer. It essentially causes you to kind of rethink this, and then your brain reloads up, and it encourages the wiring. I'm oversimplifying dramatically for any PhDs in the room. It encourages the wiring to reconnect in a new way. And there's a lot of science behind that, but there can be some interesting moments in the recovery bay. So how we think about that needs to definitely be driven by how they manage their program.
And then let's see, I believe I saw that Jean was able to join us. Jean, are you here?
I am, and thank you very much for the opportunity. And I just wanted to say that after you've seen this presentation, that we believe that behavioral health facilities in general and these academic medical center facilities specifically provide a great and much needed opportunity to apply our research into the impacts of the built environment on supporting patient outcomes and staff satisfaction. And our teams have been using an evidence-based approach to develop the positive effects of improved acoustics, the access to daylighting and views, and tunable lighting to enhance circulation rhythms as a mean of reducing sentinel events in these settings. And as we presented, the similarities and differences between these two particular facilities, and you can see that there are many opportunities for research to further compare and contrast the implementation of these design strategies on enhancing the care models that have been designed. And we at Perkins&Will are fortunate in being able to have these two projects going in parallel with two major academic medical center clients who are also very focused on engaging in collaborative research. So we'll be excited to share as a follow-up our findings and what we learn from these two projects after they're completed and occupied, and we do our post-occupancy evaluations. So thank you all very much for having us today, and I'm happy to turn it over to Q&A.
Jean, thank you so much for taking the time. I know how busy you are, and it's great to see you. It's been an excellent presentation, and we appreciate your interest and support of our programs very much. So,
Well, thank you. We're a big supporter and big fan of Aggies.
and may I say that you were a pioneer. I believe you either were the first female graduate of our college or among the top 3. There's seems to be some question, and I don't think anybody really knows for sure, but you paved the way and are a great role model. So
thank you very much.
Thank you.
So I'm sure you all have questions.
Yeah, come on, folks. A question for Jean. You know, she's a very significant figure in this health area.
No, actually, I meant questions for the team on the presentation.
Oh, okay. Well, whatever.
George, pay attention.
Yeah. Well, you know, I was a troublemaker when I was a student, so nothing's changed.
Nothing's changed.
Is that the conclusion of the Perkins&Will presentation? You're open for questions in general?
It is. We're open to take any questions. I can't see the chat, so I don't know if any of them have gone into the chat, perhaps.
No. I don't see any yet.
I can ask a question.
Do you think you could open up the screen to, it's a beautiful building, but it'd be nice to see.
No, I'll close this so that we can go back to seeing human beings again. Yeah.
Thank you.
I can ask a question. Thank you all so much for coming and presenting these projects. They're absolutely beautiful and so clearly well thought out. The question I have is kind of about design, both in regards to this project and in regards to many projects that y'all make. I know at the beginning you mentioned design, once you've done one hospital, you've done one hospital. And my question is, when you'll design one hospital and then design another hospital, or one building and then design another building, obviously you want to be, as you mentioned, very unique and specific to that project. do you find yourselves often like purposely doing different things so that it is different? Or do you find that like the difference comes from your case studies and from, is it what I'm more so saying, is it an explorative difference, or is it a difference driven by the project itself?
Well, I'm happy to start the answer to that, but I would love specifically for Jean to chime in on that. I think that the differences come out of a number of factors, but it's typically driven more by the unique features and constraints of the project itself than our desire to necessarily best ourselves or try something different just for the sake of trying something different. Healthcare, of course, as I'm sure everybody on this call knows, evolves so quickly. The technologies evolve quickly. The political climate that creates the funding mechanisms for the projects is ever evolving. So, you never find yourself in the same set of constraints from one project to another. So, we can take a look across a number of projects. Let's say we've done 6 surgery centers. We can take a look across them and say, we think that there's some best practices that are generally coming out of, the collective work that, we would carry from project to project. But, typically there is some new challenge that presents itself on every project that wasn't present at the previous one and won't be there for the next one, that we're responding to, and that by its very nature causes it to continue, to evolve. But Jean, I'd love to hear your take on that.
Thanks. And, I totally agree with everything Diana just said, because we are always looking to innovate and to develop new ideas and new approaches. But I think we work in the context of some foundational principles that we believe as a firm and that every project should embody. And some of those are things like optimizing daylight so we can get as much healthy light and views for every occupant of the building, staff, students, patients, etc. And secondly, clarity of organization and clarity of wayfinding and circulation. If you look at a plan of a facility, it needs to look simple because the people who engage with the environment are already stressed and already confused, and it's a new environment for them. So the wayfinding needs to be absolutely clear. And then, of course, we look to be efficient in our operations as we plan and design. And lastly, but not least, we always try to build in flexibility and adaptability so that our facilities can change over time, but preserving the basic concepts that I just talked about, of clarity, efficiency, and beauty, which needs to override and support everything that we do in the facility. Because at the end of the day, it's all about that individual experience with the facility.
I see a question in the chat about what we did to accommodate virtual care. And I wonder if maybe Kevin or Sarah could chime in on, how much we're seeing the use of telemedicine in psychiatric care environments.
Diane, I can jump in on that. During COVID, I had a very long interview with Stephen Glazier, who's the Chief Operating Officer of the UT facility, as well as Dr. Homer, the Chief Medical Officer at Duke, and quite a few others, trying to understand that very question, how they were responding to COVID and what that was meaning. And one of the things that was hit on in that question exactly right, which is where there was a lot of reluctance to use virtual tools in the past, they were now forced into it. And in a lot of ways, they found it was far more successful. There were a lot of families that were undergoing hardship to come and visit their loved ones in the hospital physically. And when they were no longer allowed to, they found that more visitation was possible because, you know, sometimes the nearest hospital where you get a bed is really far from where your family is. And if it's a long drive, it just may be harder for them to get there. They may have family obligations or other things. And so generally what all the facilities I've talked to found was that once they were forced to engage really in using virtual tools, they found it very, very successful. They found that the physical design of the space already worked well because psychiatric inpatient units and outpatient are designed to keep people for separation and keeping people safe in an environment. So it really just took some operational adjustments. Some hospitals went so far as to separate out one unit as the COVID unit, where they would put anyone who was at risk until they'd cleared protocols. The biggest challenge, many of them said, was just keeping their staff safe and the staffing issues. At one point, one of the hospitals I talked to had their entire admissions department came down with COVID, not literally, but most of them, and they had to scramble to figure out how to keep that portion of their operation operating. So I think it was harder on the staffing side than on the clinical side.